So
Good evening, everyone. Yeah,
sorry,
we welcome you on Ortho TV Online in association with Oref. To introduce today's speaker and topic, I hand over to Oref Chairman, Dr. John Mukhopadhyay.
Okay, good evening, everybody, and welcome to this today's webinar aimed at DNB students and postgraduate students, as well as young orthopedic surgeons. And today we have the pleasure of having Professor Hitesh Shah from Manipal, that's Kasturba Gandhi Medical College and Hospitals, Manipal, and who's a well-known figure in pediatric orthopedics. And he's going to talk about miscellaneous pediatric cases. So this will be aimed at looking at patients, trying to get a diagnosis, a differential diagnosis, and how you would plan their management based on your clinical and radiological findings. So it's a great pleasure to have you again with us, Hitesh, and over to you.
Thank you, Dr. John. Good evening to all. Thank you for sharing the opportunity, and we'll talk some of the different cases, some short cases that would be useful for the clinical exam. And for the DNB exam, the new pattern of the examination include the OSCE. So they have some of the scenarios and case to be kept, including clinical scenarios and X-rays. So we have the mixture of the cases. We prepared some cases on that. We will discuss one by one. Few points or few lectures I have taken, like the Perthes disease, and so I'm not going to include the big long cases. We'll include some of the short cases which is not discussed yet. So I will share my presentation. Okay, my screen is visible.
Yes, sir.
Sorry, now it is. Need to go full screen though.
Yeah. Now it's okay?
Yes.
Okay. One of the common case scenario in OSCE has been kept as the foot deformity. The most common case is clubfoot. So, but I am not discussing clubfoot because many times the clubfoot and the part of the clubfoot, idiopathic and non-idiopathic clubfoot, has also been kept. So it is very common, but some of the postgraduate examiner will expect that to talk on the clubfoot and Ponseti principle for the postgraduates. But we do see some of the other congenital anomalies and the foot anomalies. So we talk on the foot anomalies, some leg anomalies. We have discussed of the angular deformity, tumors, cubitus varus. So those cases I will not discuss. So the most important aspect of the foot deformity, any foot deformity, whether it is clubfoot or varus or valgus, is required to have the important to the age and onset of the deformity, where the onset of the deformity will give idea whether it is a congenital problem or an acquired problem, whether it is a child or adult. But we are mostly focusing today on a child. So whether all the foot deformity is a congenital in nature, very common is congenital talipes equinovarus or the congenital rocker bottom foot or the congenital vertical talus. That is most important to see. Important aspect of the congenital vertical talus or the CTV, it may be associated with the multiple congenital problems. So you need to ask whether it is associated problem or not. And another important aspect, we need to ask whether it is a progressive or a non-progressive deformity. Most of the congenital deformity due to the non-neurological cases, it would not be progressive. But if it is associated with the neurological issue, it would be progressive. So we'll have the case scenario. This is the child present with the 1.5-year-old following a delivery. It's an age and the deformity since birth. So any of the postgraduate can describe what they can see. From front, sole, and from the side views, the same child.
Yeah, I think
Avinash.
Yeah. Yes, Avinash.
In first pick left side upper, the metatarsal adduction in forefoot, and second in third is the there is a spherical sole, and there may be the congenital vertical talus.
Oh, okay,
What do you mean
how
by
would you describe? You said
spherical? What do you mean by
metatarsal.
spherical sole?
Yeah.
Sir,
So,
round shape sole here.
okay, so sphere means a full circle, okay?
Yes.
So you say convex, yeah?
Convex.
Okay.
Yeah, but you said it's metatarsal adduction. Is it a metatarsal adduction?
Yeah. First one. Yeah.
You said it's. You said first one is metatarsal adduction. Is it adduction?
No, sir, abduction.
Abduction. See, it's important question in your DNB exam, also in ASCII, very common question. What are the deformity of clubfoot? Another asked, what are deformity in this child? Third question, what are the deformity of the congenital vertical talus? So when it is very important to describe the deformity of the ankle and foot in the child. So what is required in the said, as Dr. John said, that it is a convexity. The normal contour of the sole has been lost. So plantar surface is a rocker bottom. It is like a rocker. It is not. The convexity is there on the sole side. What is there on the hind foot? Hind foot means back side of the foot. The hind foot would be the equinus and the valgus. How do you say it equinus? If heel is pulled up, that is equinus. And compared to the longitudinal axis of the tibia, if heel is going laterally deviated, it is hind foot valgus. So it is important to say deformity of the this child is having hind foot equinus and hind foot valgus. If you see the forefoot is abducted, everted, and dorsiflex. So you can see the contour of the sole has been lost. It is convexity. The hind foot equinus, hind foot varus. The forefoot is abducted, dorsiflex, and everted. So remember, the hind foot is also in pulled up, and forefoot is also pulled up. Talus is only one structure in the body. Doesn't have any muscular attachment. It is suspended with the calcaneum. It goes. So backside of the heel is also pulled up, and the front part of also the forefoot is also pulled up. These are the inspectory finding. If you get the case in the actual in clinic, sometimes you can see in the prominence of the talus would be there on the medial aspect. So you can see in a sole, that is also important. And for the even weight bearing surface and the soiling of the skin by the touching on the ground, you can see, make out what part of the foot is in contact with the ground when child weight bears. Okay, so it is important the medial rays are touching. Again, the previous one, the lateral rays off the ground. If you see the previous, the lateral side is off, the medial side is touching. So that is the most important aspect of the vertical talus. It's a small heel, and anywhere it is the equinus deformity, heel is the small, and convex plantar border would be there. And if child would be walking, you will see the big callosities on the medial aspect at level of the talus. So these are the important the inspectory finding, or by look you can make out. Okay, what is to be checked in the palpation, if you get the case, whether you can see that the passively correctable or not. When you check that the both side is vertical talus, the child comes with that's everted the forefoot, whether deformity is supple or not, whether it's a passively correctable or not, whether the talus is palpable, or whether it is the tightness of the TA and the empty heel sign is present or not. Okay, the hind foot equinus, but the hind foot equinus, the empty heel sign is suggestive of the hind foot equinus. You can see in a palpation, and that has to be do in palpation. Okay, what need to check in the movement? We need to check the movement, whether it is the passive movements of the ankle, subtalar, and the mid-tarsal, whether it is a fix or not. And always check about the hip and knee range of motion. I will ask the postgraduates, any other examination they like to do? Because that is another question. You saw this is
Examination, sir.
You nearly gave
Examination of
it away.
spine.
examination of
Spine.
You gave it
Fine,
away,
okay.
Hitesh.
Huh?
You gave it away by clicking on the next slide.
Oh, okay.
Just for a moment.
Okay. No, I thought I will take a break on that, because see, what has to check on it, look, feel, move. Then I am not going in measure, because it's just quick the cases. Then we need to say, you need to check the spine. Okay. What will you check in spine? Good. And why need to check? What will you check and why would you check?
There may be a spina bifida or tethering of the cord in meningocele,
Okay.
or it may lead to the neurological
Okay. So,
neurological problem which lead to the neurological CTVC.
So if you have a meningomyelocele, it will be visible, okay? Tethering of cord may be completely invisible outside, or you may have some subtle signs of it. What are those?
Yes, Avinash.
There may be hyperpigmentation or tuft of hair.
Okay, tuft of hair, what else?
Dimpling may be there.
Okay, what else?
Nevus.
Yeah,
Okay,
okay.
sir.
Hitesh, anything else you want to add to that?
yeah, it is that or whatever is they said is correct. The swelling, nevus, neuromercanous markers, pigmented patch, sometimes the tuft or hair, very subtle sign will be there in tuft or hair, or sometimes it is the dimple would be there, or
Yeah.
sometimes at the apex of deformity, that will give you the idea about the tethering. Or today also I have seen one child with even the swelling would be there, like a big swelling would be there. But
Yeah.
as Dr. John said, meningomyelocele, and it will be having swelling, where the diastomatomyelia and all other spinal dysraphism, it is not the swelling would be there. It is just subtle sign would be there. Another important point for the underlying neurological disorder, the size of the foot, if it is asymmetrical, always think about the neurological case. Okay, and whenever we suspect any the foot deformity, always palpate the spine from the top to bottom. Okay, and what you need to palpate the spinous process, because many times it may be missing by only palpation, may not be present in a subtle sign. Okay, another important question, why need to check the hip and knee?
Yes,
Actually,
Avinash.
sir.
Yeah.
Actually, sir, DDH is associated with the CTV or foot deformity, sir. And in knee, sometimes blount disease also, sir.
Vertical talus would not be associated with the blount
But I think
disease. Blount disease is different.
Blount
Okay.
disease is totally different. Yeah.
Different, yeah. This is congenital problem. Blount is never congenital.
maybe he's confused with that packing disorder, like with the CTV, what DDH and other things are there, sir. That's like torticollis and all. So, sir is asking what not CTV but CVT is one congenital vertical talus association.
Yeah, but again, any congenital foot deformity, you can have
Yes.
Other congenital anomalies. Okay.
Yes. The one of the commonest anomalies also would be like a congenital contracture. or
arthrogryposis.
multiple.
Yeah.
Yeah. So that is the reason you need to always check the upper limb, always check the hip and knee. So wherever there is a flexion or extension, contracture of the knee would be also associated. And another important point, where this systemic examination, because this would be also a part of your ASCII question, the clubfoot, the 80% of your clubfoot would be idiopathic in nature, while the vertical talus, it is not 80% are idiopathic. 50% are always non-idiopathic. It would not be associated with the idiopathic. It will be associated with some syndromes, like it will be associated with trisomy. It is associated with chromosomal anomalies. It will be associated with multiple congenital contracture. It would be associated with the spina bifida. Okay, so always check. A journal examination is very important in case of the vertical talus. And the important aspect, if it is a neurological in case, you need to check the neurology. Like, I'm not going in detail, but you need to check it on power. You see whether the child is withdrawing when you touch or not. And this is the very important points for the any short case of the foot deformity. So in general, you need to say, look, feel, move, and do a thorough examination. Even the postgraduate would not be aware about the all syndrome, but they can say, is it idiopathic or non-idiopathic? If it is associated with the part of the systemic features, you can see the part of the generalized syndrome, which we may not be aware. Okay, so nobody is going to ask you what syndrome is there, but you can say it is non-idiopathic in nature. Okay, so finally we can say this is a case where we have shown it's a bilateral congenital vertical talus without complication, means with any trophic ulcer. Sometimes it would be associated with spina bifida, it's a breaking of spine, or the with callosity, or with any other changes that you can say with without that. And these are all the different symptoms. The terminology is a convex pes valgus or rocker bottom fluid, or the foot, or sometimes it would be called as congenital rigid flat foot, but the most common terminology is used as the congenital vertical talus. Okay, and the another question, it is being asked by the most of the examiner, why do you think so a diagnosis? If deformity is present since birth, that gives an idea about the vertical talus, congenital in nature. The shape resembles like rocker bottom, the sole, and whether the hind foot, the deformity, typical deformity is hind foot valgus and hind foot equinus, and there is a forefoot abduction, forefoot dorsiflexion, and forefoot eversion, and a tight tendo-Achilles. If the spine and all rest of the systemic examination is normal, you can take it's a idiopathic in nature. If it is abnormal, you can say that is non-idiopathic. If it is a contracture of multiple system, you can say multiple congenital contracture. And the spine is abnormal, you can say underlying spinal dysraphism. That includes spina bifida also. If there is a swelling is present, you can say the case of the spina bifida. If it is swelling is not present, you can say spinal dysraphism. Okay, what will you do? This is the clinical diagnosis. It's a congenital vertical talus, bilateral, idiopathic, congenital vertical talus. What will you do? Any postgraduates?
Sumit, management sir is asking.
Reverse Ponseti technique.
Okay, you want to say reverse Ponseti technique. Okay, good. The child is 2 years. Would you do it with reverse Ponseti?
Yes, sir. To relax the or lending the soft tissues.
Okay. Before that, Sumit, it is very good. You learn the reverse Ponseti and you said about reverse Ponseti, but always remember in your DNB exam, whenever you will have clinical diagnosis, what is always next step? You like to confirm the diagnosis?
Confirm by investigation.
Okay. So what is the investigation of choice? In orthopedic, we are going to be orthopedic surgeon. So what is the commonest investigation?
Commonest is sir X-ray.
Okay. So if you suspect, what is this case we are talking?
It is the congenital vertical talus, and
So tell me one investigation with one view, you can confirm this is case of congenital vertical talus. So that is also one of your ASCII question. Single investigation, single X-ray.
Lateral view of the foot, sir.
Okay, is it only lateral view of foot? Anything
Yes, sir,
else?
only.
You need to add something? You need to add something on the lateral view of the foot? It's correct, but it's partially correct. It's not fully correct. If there is ASCII, you will get half mark, not full mark. 1 mark if you want to. Or if it is 2 mark, you'll get 1 mark.
Weight bearing or?
So if it's a really small child, how do you do a weight bearing X-ray?
Yeah, it's you suspect it less than 1 year, so you can't have the weight bearing X-ray. Any other postgraduates? Any other? If it is not, we'll go ahead. Okay, so most important is that the plantar flexion stress view X-ray, the plantar flexion. Why it is having plantar flexion? Because the forefoot is dorsiflex. So whenever forefoot is dorsiflex, in case of the cerebral palsy, it may case of the neurogenic foot, in case of gross ligamentous laxity, in case of the congenital oblique talus, in case of the syndromic ligamentous laxity, they will present like the planovalgus, and these are acquired disease. If you want to rule out vertical talus versus oblique talus, the most important X-ray is the plantar flexion stress view, plantar flexion lateral stress view. Okay, what you need to check? You need to check the longitudinal axis of the talus and longitudinal axis of first metatarsal. If the longitudinal axis of the first metatarsal is passing dorsal to the longitudinal axis of the talus in forced plantar flexion views, it will say it is a confirmed case of the congenital vertical talus. Okay, remember that this is the most important point, because the many condition will have the planovalgus, and if you take even a stress weight bearing, or if you take any views, you will find that talar axis normally, okay, I did not say about normal, normally both are matching in a normal lateral view, but in case of the ligamentous laxity, the first ray or the first metatarsal is dorsum to the talus. But when you do about plantar flexion, means it is not coming in line, that means it is congenital vertical talus. Okay, this is the most important part. If the examiner wants, or you want to take the X-ray, you need to take the APU to say what is the relationship between talus and calcaneum. Talocalcaneum angle would be higher, more than normal. In case of the clubfoot, talocalcaneum angle tends to be 0 or reduced. In case of the vertical talus or hindfoot valgus, the talocalcaneum angle is more. Other angles, you can say the first metatarsal angle is abducted. Normally, it is in line. Again, talus and first metatarsal in PP and lateral would be in line, but it will be abducted. And another view is the talocalcaneum angle in lateral view is more. Again, in clubfoot, it is parallel where it is more. But if somebody is asking only one X-ray, you will say the lateral plantar flexion X-ray for the diagnosis of vertical. These are the X-rays are required to understand the severity of the vertical talus. How much is a deformity? You want to compare before treatment and after treatment. Okay. So, Dr. John, you want to add something on that, the radiograph?
No, I think that's enough as far as the X-rays are concerned. I think another useful investigation in the really small child are ultrasounds.
Yes.
Of the feet. That's the only other thing. So, because yes, bones are mostly cartilaginous at that time, and you might be able to see them better on ultrasound than on that something. So that's in the really young child.
Okay. Yes, that's a very important point. I like to ask any postgraduates for what are the bones are visible here.
Vinas?
How many bones are visible?
Talus, calcaneum,
Correct.
and sir, cuboid.
Cuboid.
Then sir, the cuneiform one. Cuneiform is also visible.
Correct.
Which
And
Correct.
sir, metatarsals.
Yes.
And sir, phalanges.
Okay, excellent. That is excellent. So there is only 4 tarsal bone are there. Okay, the next question is there. Where is the deformity in congenital vertical talus? Where is the deformity at the site of deformity?
Talonavicular joint, sir.
Talonavicular. So where is the talonavicular joint? Normal relationship or abnormal relationship?
Abnormal relationship.
What abnormality will be there in talonavicular?
Navicular is displaced dorsally in compared to the talus, sir.
Okay, one is dorsally and
only
in what
dorsally
about
or some? What about in the coronal plane?
Yes.
Medially also, sir.
No. Not medially. Navicular is medially in clubfoot. In case of vertical talus, it is displaced opposite to medial. What is that?
Lateral.
Lateral.
Yeah,
So,
because the head comes out medially. Yeah? Unlike in the clubfoot where you'll feel the talar head on the lateral side, here the talus goes towards the sole.
plantarverse and medial.
Yeah. Okay. And the navicular
So,
go
remember,
on top of the talus and laterally. Okay. So it's sometimes very difficult to, if you're doing surgery, which we used to do a lot earlier, we try to now reduce the amount of surgery with casting. But initially, when we used to do these extensive release, it was very easy to go right into the navicular if you weren't careful.
yes, it's very important. It's a dorsolateral subluxation or dislocation of the talonavicular joint. Dorsolateral. So navicular is dorsally and laterally. And again, the important part, as Dr. John said, that navicular is not ossified before 4 years. So if you want to take X-ray, it's indirect evidence. You need to say navicular, talus, and the first metatarsal is always in line. So you take about the proximal part is the talus and distal part as the first metatarsal. And that is the reason you need to check all this on the X-rays. The other radiograph depends on the pathology, like this is a case with the sacral agenesis, where the sacrum is absent, or you can check the hip X-ray or the knee X-ray, depends on the syndromes. If there is a syndromic child, you need to take a skeletal survey. Okay, how do you treat it? It's a case of vertical talus, 2-year-old child. Yes, somebody's already said it is a reverse ponsity. So I'm not going in detail. That is the why need to treat that, what is the treatment is there. But the treatment option is serial manipulation or casting, or the operative the intervention, whether it is required to have soft tissue tendon transfer or naviculectomy. But important, please understand that the Matthew Dobbs described the reverse ponsity. The ponsity we put at the pressure at the head of talus. Similarly, that you can apply your thumb on the, that is on ponsity technique on the lateral side, because the head of talus is on lateral side. Here the head of talus is on the medial side. So you can put, and it put in reverse, where you do abduction and external rotation in ponsity, while you do the adduction and inversion in case of the reverse ponsity. But remember, as the ponsity techniques will have a very good result in case of the vertical talus, the similar result may not be applicable to same extent to the vertical talus. The reason being that there is a complex deformity of the forefoot and hindfoot. Even the Matthew Dobbs says that after correction of the equinus and the varus, you need to require the minimal invasive open reduction of the talonavicular joint. Okay. So what is your experience?
Also, when you're casting it, you have to remember that you're pulling down the forefoot, but you also have to pull down the hindfoot. Unlike in a clubfoot where you're doing them in more or less you're only doing it in one direction. Here you have to actually do two opposite directions for the heel and the front of the foot. So that's something you have to remember.
Yes. So how is the result? Up to what time you can do about the serial manipulation and casting? Every single child with vertical talus?
Yes, Sumit, it is for you. Yeah.
Till the child starts walking.
Okay, till the child starts walking, it would be a good answer, because the older age, the soft tissue contracture is severe. Again, for the safety side for a postgraduate, if sometimes some conservative surgeon will come in your exam, you can say about serial manipulation and casting, but it may not correct the deformity fully, but it will reduce the deformity. So the severity of the surgery or the extent of the surgery requirement would be little less. Okay, so you can do about the manipulation and casting, but again, older age group, even the Matthew Dobbs and other people, they don't have a good result beyond 2 to 3 years of age. Okay, so the other operative intervention would be required. So that option includes soft tissue release, standard transfer, naviculectomy, subtalar, or triple arthrodesis, depends on the age of the child. Okay, so
Sir, how it is done according to the Dobbs method?
how it is according to done in a yes, you need to do the forefoot into plantar flex inverted and adducted. Okay, you need to correct the deformity of tendoachilles by tendoachilles tenotomy, and talonavicular joint would be with the open. Again, it's not a close. Initially describe about the close, but if you see in a literature very carefully, the number of the recurrence or with close KVR is not very good. So you need to do about opening about capsule and reduce about the talonavicular joint and maintenance with the KVR. Remember, in case of the Ponseti technique, there is no use of wire, there is no use of open surgery, there is use of only tendoachilles tenotomy, and that is in OP basis. Where here, in case of the reverse Ponseti or the talonavicular joint reduction by open reduction and fixing with the K-wire, it's across the talonavicular. That is the basic principle of the Matthew Dobbs or the reverse Ponseti. Like that, you need to do to the adduction and inversion, and then you do about that. This is a child with abducted and everted, put the plaster in the plantar flex and inversion, and after fix with the talonavicular, maintain with the plaster, and this is the result. It looks reasonably okay, and it's been maintained also in a follow-up. It's quite okay in the reasonable. It's a quite supple and pliable foot, and this is the X-ray before and after the 5-year follow-up has been maintained. Okay, so I'm not going in detail in operative treatment. In older child, different methods are required. Dr. John, you want to add anything, or should we talk on something on operative, or should we go on other case?
I think it's okay, because it's. I think there are many things to consider in the surgery which you need to look at. There are many tendons you have to release if you're doing it. All the anterior structures, the posterior lateral structures, all have to be released if you're in the very late cases, because it's quite a huge or horrendous surgery when you come to the late cases.
Yes. Yeah, so in other sense, it is the, you can see the pictorial diagram that the talus is vertical, the forefoot is been the abducted, everted, and dorsiplex. Same time, the hindfoot is in equinus. So when you do about talonavicular reduction, you do with some distraction. Then do about the plantar flex, pass the wire in a joystick after doing tendoachilles lengthening, pass across it, put it on lever, get it into the correction of the equinus, and join it together and pass the wire. Okay, it looks good in this animation, but this is actually we need.
Yeah, and you have to be careful where the wire goes, because it's not in a small child. There are some structures around which you can damage, so you have to be very careful.
Yes. No, for the understanding of the
No, I know, absolutely. That's what I'm saying. So I'm just saying that it's great on the animated diagram, but it's not as easy to do in real life. And the bone is also most often just cartilage, so you have to be very careful in passing the wires.
Yes. So you need to do about, as Dr. John said, you need to do the lengthening of the dorsum structure. You need do the
Lateral structures.
lateral structures. You need to
Posterior as well. TA has to be lengthened.
Yes, you need to do about the posterior structure, lateral structure. Dorsal is the tibialis anterior, EHL, EDL, peroneus tertius, lateral structure peroneus longus and brevis, and posterior is tendoachilles and the capsule. And do about the talonavicular and calcaneocuboid and fixation with the wire. And some people do the tendon transfer, tibialis the anterior.
Anterior
This
to
is
the neck.
Yeah, anterior to the neck. These are the few steps or the plaster and fix with the wire. So I'll show you there just quickly on that some of the vertical talus, and it's got corrected and reasonably followed for the long time. It's reasonably okay.
So Hitesh, have you found the numbers of these reducing recently? Because I remember we used to do a lot of them some years ago, and now I haven't seen many of them in the last 2 or 3 years. I don't know why.
Yeah, it comes in bunches actually.
Comes
Sometimes
in bunches,
it will,
yeah, that's true.
Yes, sometimes it will come in bunches, and sometimes for the 5-6 months nothing would be there. Then sometimes the 5-6 will come together.
Yeah, that's true of a lot of things actually.
Yeah, it's so this is some of the most striking is that in the non-idiopathic clubfoot, the shape of the talus is also the funny, where it is very constricted on the neck. But that would be in a detail, but they need to understand the relationship between talus and first metatarsus.
Yeah, and also these non-idiopathic ones, the results are not great, whatever you do to them.
Yeah, it's there, but recently we published on JPOB the idiopathic and non-idiopathic. The morphological it's okay, but the functional result, the idiopathic is having much better. Okay, so in short, we can say the lateral view in plantar flexion to rule out the oblique talus. Always exclude the other anomalies. Non-operative treatment is effective in young child, and surgery is required in older child. Okay, any question on that? Or
I think I can move on another case.
Okay. We'll have the simple case. I'm not prepared the lecture, but just a case. So you can have spotters. The left side, the photo screen is visible. The PowerPoint.
Yes. Yes, sir.
Yeah.
Yeah, right side child born with the deformity of tibia, and when it's become the 3-year-old child, this is a deformity. Can you describe what is the diagnosis? Spotters.
Yes, Sumit. I think we have Sumit, Avinash, Sachin.
Yeah.
Yes, Sumit.
Valgus.
Sorry?
Yes.
Ankle valgus.
Ankle valgus. What's the diagnosis? So you're seeing the follow-up on the right side, okay? Yes. Or on the left side as you're facing it, okay?
Have you seen this? Okay, let us talk on that, whether tibia is straight, whether knee and ankle is in line.
No, sir.
Okay. So what's wrong with the tibia?
It's going medially. Tibia is going medially in distal part.
It's going medially.
Okay.
Medially that.
Medially.
You mean
medially
apex
and ankle.
Medially? You mean apex medially?
Apex is medially, sir, but
okay.
Ankle is.
Okay, is it only medial or something else?
So there is bowing of tibia. Convexity is towards medial side.
Okay, is it just medial or do you think there will be something else to it? Okay.
Medial.
On this, maybe on this view, you can't tell for sure. Okay.
Yes, it's there. Okay. Now this
So
is the
it's
X-ray.
So it's usually a posteromedial it's called posteromedial bowing, okay? Although strictly speaking, that should not be the correct term for it.
Yeah,
Like,
but we can stick to the
it's the opposite of
postgraduate.
anterolateral bowing, so we call it posteromedial. So nowadays, when you talk about deformity, it's best to talk in terms of the apex of the deformity, okay?
Yeah, so the apex of deformity is on medial side and posterior side. So this is called as congenital posteromedial bowing of tibia and fibula. Okay, what will you do? That is another OSCE question. So there's small spotters.
How will you treat this? Will you protect
Sir,
it?
only manipulation for 6 months, sir.
Manipulation. What do you manipulate?
There is no joint. Oh, no, can
So you manipulate the bone. Well, actually, people did that some time ago. So I guess.
Splinting of the leg.
So what's the natural history? Come on. If you know the problem, you'll know the natural history, and the natural history will tell you what you should be doing. Okay. So Sumit, what is the natural history of posteromedial bowing of the tibia? Does it fracture?
No, sir.
No. Pardon? Can you talk louder? I can't hear you.
No, sir. Fracture is not ready, but not a.
So it is not prone to fracture, unlike anterolateral bowing. Okay, fine. Then what else? Does it correct itself?
No, sir.
No.
It might get corrected with observation sometimes.
Might get corrected.
Okay, that is the reason this, before going for all different bowing, I thought first and foremost I'll put the most benign variety.
Benign form.
Okay, please. Most benign form of the tibial bowing is the congenital posteromedial bowing of tibia. The most of the deformity, by and large, most of the deformity gets corrected, but it's not all are the corrected 100%. Second important issues that are there is having shortening. They will always have the some sort of, if you see the child from the birth also, if you very carefully see, the right lower limb, right leg is little shorter than left side initial also.
Yeah,
okay, so it is
interesting. It's interesting when you see these children very early, you'll find that the foot is almost along with the tibia, okay? So it looks very odd, but gradually it corrects itself, okay? The deformity mostly corrects itself. They're left with some deformity, but the real problem that all of them are left with is some shortening around 4 centimeters or so. That's the average.
Yes.
It could be more or less.
Yeah, the natural history is like that. If you see the child, it gets corrected. If you see that, we are fortunate to see some patient for following on long term. So if you see that from the 6 months, the same child, if you see it gets gradually, it gets straightened up. And this is the most striking part of the congenital posteromedial bowing of tibia. If you see the slowly, it will get it stretch up. It doesn't require any other intervention than the sole raise. And you need to follow these children in regularly to find out how much amount of residual shortening you can expect at the maturity. Depends on that, you can plan. Some of them will require only sole raise. Some of them will require the opposite tibia epiphysiodesis. Some of them will require the limb lengthening, tibia lengthening. Okay. Another aspect of the residual problem, sometimes they may have the ankle valgus also whenever it is associated with the wedging of the distal physis, distal tibial epiphysis. And those cases will require the screw epiphysiodesis or growth modulation. But by and large, this is the one of the story that it will get it corrected by its own.
So, sir, for OSCE, the answer should be observation, sir.
Yes, observation and serial follow-up for shortening.
And you may have to plan lengthening later or whatever. So either you do
Yes.
a epiphysiodesis of the other side so that the limbs end up equal. We
Yes.
find it difficult to convince patients on shortening of the other side. So it's usually lengthening for us. But I think if you, in some ways, it's easier to do an epiphysiodesis than do a lengthening.
Yes. We'll go on the next slide. Is visible?
Yeah.
Yes, sir.
No.
Yeah.
Okay.
Yeah. Now. So
now, can you describe the deformity?
So anterolateral bowing of tibia.
Yes. So it's good. So it's anterolateral. Okay. What would you examine in case of the anterolateral tibia bowing? Would you like to? There's another OSCE question. What will you examine? Very quickly, you need to examine.
Sorry. Come on. These answers should come like that. Okay. So what is the disease it's often associated with?
Pseudoarthrosis of the tibia.
Pseudoarthrosis, but what is pseudoarthrosis associated with?
Neurofibromatosis.
Neurofibromatosis. So what do you look for in neurofibromatosis?
Cafe au lait spot.
Cafe au lait.
Okay, cafe au lait spots. What else?
Axillary frankel.
Yes.
Sorry?
Or axillary frankel.
What? Axillary? What?
Sorry, sir. I don't remember.
Sorry?
I don't remember, sir. Axillary something. Axillary frankel.
Frankel. What is frankel? You mean freckles?
Freckles.
Yes.
Okay,
And
you need to check about for the
What is?
neurocutaneous.
Huh?
Neurocutaneous swelling, sir.
Okay, so you can get multiple
Neurocutaneous.
Okay.
swelling.
What else is the one of the big problems if you have neurofibromatosis that you might have? Any
Spina
in the spine? Yeah, what?
Spina bifida.
Spina bifida? What do you get in the spine? Have you heard of dumbbell tumor? No?
Yes, sir.
So what is that? And why is it called a dumbbell tumor?
Histopathologically, neurofibromatosis is seen as the dumbbell shape.
So why is it called a dumbbell tumor? And in the spine, why does that happen? Okay, anyway.
The important aspect to check about the systemic examination, the most of the neurofibromatosis, at least 60 to 70% are associated with the neurofibromatosis. So you need to say whether it's a neurofibroma is there, the capillary spots are there, the axilla and groin need to check. You need to say the glioma on the eye. You need to check the scoliosis, whether it is having congenital type or dystrophic type or non-dystrophic type scoliosis. And many times it would be associated with the hemihypertrophy. So you need to check about the limb. Okay, so this is the X-ray. Can you read the X-ray? Same child. Is it the, what will you describe? Is there the fracture, or it's no fracture, or it's only bowing, or it is associated with bowing with fracture?
So there is a bowing of tibia
Okay.
at the junction of distal 1/3 and proximal 2/3, and as well as bowing of fibula at the same level associated with the fracture.
Okay.
The fibula.
There is a fracture of fibula. So, okay, this is a typical case of the anterolateral bowing with the fibula pseudoarthrosis. So, with the, if you can see, there is the the width of the tibia is not normal and middle third on the lateral view. Same way, the density of the tibia, there is no corticomedullary differentiation clearly on the middle third part of the tibia. At the same time, there is a sclerosis. There is some cystic area is also that upper third, middle third junction. So what will you do? How this is different than our posteromedial bowing?
So
How this is different?
Not healing, sir. I have to
But is
intervene.
it tibia is fracture? Is it tibia is fracture? Does the tibia is intact or it's the fracture? Tibia.
So tibia has also fracture in lateral view.
Fracture in lateral view, sir. One cortex is one, sir.
Okay, you want to stay in one cortex. Suppose it is not fracture and like this, would you do osteotomy and correct it?
So if the patient comes to you in this position, there's no fracture, what would you do in other words?
Sir, like to brace it and observe it.
What
Okay.
kind of brace?
Patellar
Okay, good.
Huh?
Good. Yes.
Patellar tendon bearing.
Brace. Okay. So that's important question is there. Whenever there is anterolateral bowing without the fracture, you can protect it, or you can do about growth modulation and get it corrected. And the third also, the another option is been described in the literature is McFarland bypass. But by and large, you don't do the cutting of the bone. If some examiner insists, what is the latest thing are there? The drawer palette describe about cutting about that, but the important aspect is there, getting into non-union, it's very, very high. So whenever it is a sclerotic bone, you don't try to cut it. The message is there, you can protect to prevent the fracture. Okay, once it is there fracture, it's one of the most frustrating problem for almost all. Okay, it's never unites. Many people claim that it will unite the 100%, but this is one of the most challenging problem throughout the pediatric orthopedic condition. So the basic principle is to prevent the fracture. Okay, another child similarly, the anterolateral bowing and having the capillus spots, and this one, and this is a X-ray described. So this is another child, not the same child, but the similarly bowing is similar, anterolateral bowing with this capillus spots, and this is X-ray. Can you describe the X-ray?
Sir, non-contrast normal radiograph showing tibia and fibula with tibia anterolateral bowing and fracture at the level at the junction of distal 1/3 and middle proximal 2/3.
What do you mean by normal radiograph?
Yeah.
Sir, plain.
So plain X-ray or plain radiograph, huh?
Yes. And
You can say the plain.
So when you talk, when you know there's a fracture, never say normal radiograph. Huh?
Yes. So there is generalized osteopenia.
Okay.
There is cystic lesion also there, sir, in tibia.
So when you say generalized osteopenia, then you say there are sclerotic areas as well.
Yes.
The sclerotic areas are there.
So then how is it generalized? So the areas of osteopenia and sclerosis, okay? So don't get yourself into trouble, yeah?
Yeah, you can say the both end of the fracture end looks fresh or it's old.
Yeah.
It is tapering end.
Tapering ends, yeah.
Or non-tapering end.
Yes, it has tapering end.
See, so your description should be, yes, your description should be crystal clear that this is a pathological fracture. This is not an acute fracture. And if you see the tibia on the lateral view, proximal third tibia, is it straight? So it's also bowed. So this is a case where you can say that's a pseudoarthrosis of tibia and fibula, because many times it will be asked, why do you think so it's a pseudoarthrosis? Why do you think so it is not normal fresh fracture? Why do you think so it's a pathological fracture? So if your description says the sclerosis, lysis, bowing, tapering end, then there is a sclerosis at the end with the blunt end. You can say these are the part of the pathological process. So this is a case of the congenital pseudoarthrosis tibia. One word, what will you do? That is your OSCE question also. What is
Nailing
the
and bone
treatment?
grafting, sir.
Open reduction internal
Nailing and bone
grafting.
nailing and bone graft.
Nailing and bone grafting.
No, sir. Open reduction in internal fixation and bone graft.
Open reduction and internal fixation. Wow. We've seen a few cases treated in.
So many cases, sir.
Huh?
For so many cases of pseudoarthrosis they have seen. They are not able to answer.
Is it the same way we
The
treat
main
our tibial fractures?
No, sir.
Then, so what do you do? What do you find first? In the area of the pseudoarthrosis, what are the operative findings that you expect?
Synovial fluid.
Synovial. What about the periosteum? What about the sclerotic bone? What are you going to do?
Would you get the normal tissue at the fracture site?
No, sir.
Would you keep that the pathological tissue? It is called the hematomatous tissue that is related to the neurofibroma. It is related to that. It's a disease periosteum. It's a disease bone. It's a disease. Actually, it is a disease tibia. So it is a tibial dysplasia. But at the level of fracture, that is hematomatous tissue, that you need to remove that tissue. The answer should be the excision of the pseudoarthrosis, removal of the disease part, removal of the periosteum, till it will be bleed. So you need to have a bleeding end to end. Once it is bleeding end to end, that will take care of the biology. Then you need to have the good contact between bone to bone, stabilize with the intramedullary nailing. Then you need to give some stimulus in form of the bone grafting. So you enhance the bone grafting either will be by the vascularized or a non-vascularized or a cortical graft or a cancellous graft with the good stability in all the plane, either the coronal, sagittal and rotational. So you can add with the intramedullary nail or the alizaro. That's why there are three different types, but the basic principle doesn't change. Excision of pseudoarthrosis, stabilization with the intramedullary rod, plus the bone grafting, plus many things like periosteal graft, BMP graft, anything.
So what are the additional things that you do in pseudoarthrosis which you might not do otherwise? What about the fibula? Do you do anything to the fibula?
That is another one controversial question.
Fibular osteotomy.
Osteotomy is broken already. It's pseudoarthrosis. So why do you do an osteotomy? Don't think there's a pseudoarthrosis of the fibula?
Yes, sir. It is there.
So would you fix the fibula?
Sir, pseudoarthrosis will not unite. So we have to fix.
So but you're fixing the tibia, you're hoping it unites.
Sir, we need to remove the pathological tissues from the pseudoarthrosis site. So we have to.
It's okay. You can do that in the fibula as well, can't you? So there's some controversy about it. Some people say you should fix the fibula. There's some people who don't do it. So there is some controversy about that. But it's important that you are aware of the issues, okay?
But whenever there is a distal most part of the fibula pseudoarthrosis, you can fix it also because
it's part of the ankle.
Otherwise in ankle, so it will go in ankle valgus otherwise. So you can fix. So somebody is going to ask why not to fix it? Yeah, probably not. Yes.
And then what about bone transport?
Okay, then last case I will show.
Yeah.
Yes. Yeah, there are the challenging problem. That's that are the issues. There are the union is a problem, refracture is problem, limb length inequality, and ankle valgus. So you are focusing first on union. But if you focus on union, after that the problem doesn't end. You may get the refracture that the child walks, or because of the growth abnormality of proximal and distal end, you may land up in limb length inequality. Or because of the asymmetrical growth on medial and lateral side, you may have the deformity of tibia and ankle. That is one of the commonest deformities, ankle valgus. Okay, so the important message, whenever we see the anterolateral bowing, always think about neurofibromatosis. And whenever there is no fracture, treat with the support or the brace. If there is a fracture, no other treatment is required. Operative intervention is required. To get the union without the surgical intervention, union would not be probably possible. And once the fracture unites, you may land up with the refracture, limb length discrepancy, or ankle valgus. And as Dr. John said, you may have the limb length discrepancy. Sure, it's already 8 o'clock. We'll talk one case or we'll stop? Huh?
I think we should. Yeah. Let's call it a day because I've got to prepare one talk.
Okay.
It's great. Okay.
Fine. It's okay.
We'll do it again.
Hope they enjoyed.
Yeah, I'm sure I'm sure they've learned a lot. Thank you very much, Hitesh. As always.
Thank you very much, sir.
Yeah. Always educational and informative. And with the huge experience you guys have there in Manipal, it's always good to see. Okay. So great. Thank you very much. And we'll have it again sometime after another couple of months, I'm sure. So we'll refresh it again. Okay.
Sure. No problem. Fine. Sure. My
Thanks
pleasure.
very much.
Thank you so much, sir.
Until next time, bye. Okay.
Thank you so much.
Sure, bye.
Sure, bye, everybody.